All right, as promised, we are going to go over a review of Exam 1. Before you click into the next slide, here's how this is going to work. You've got to take a deep breath. I am not here to fail you. I am here to help you succeed. You will fail if you are freaked out while you do this. So if you are, walk away and come back to it later. I do not need you in a sympathetic nervous system process while I'm trying to teach you some pretty difficult concepts if this is new to you. The good news is I'm going to give you everything you need to be successful so long as you are calmed down and so long as you are actively engaged in the conversation. So I would encourage you to grab a snack, grab a drink, try to get into a quiet area. If you can't, then go take a car ride, and as you're doing that, just turn it on your Bluetooth, right? Turn it at a reasonable medium volume and make sure that you kind of zone out, because that's going to go into your long-term processing. Another suggestion that's probably a great idea is turn it on while you're about to sleep. Turn it on the lowest of the low where you can barely hear what's going on. That's going to be very helpful for you, because I am going to go over a lot of topics, a lot of concepts, and it's going to be okay. You can do this. You're smart enough. You're good enough. You are worthy of being successful. Please understand that. All right. Click over to slide 2 if you're ready. Let's jump into it. Let's do it. Okay, so chronic illness in older adults, we're going to just barely graze over this, and it doesn't need a lot of in-depth thought. Okay, most of this stuff is common sense, guys. So I want you to just think about it. Think about your grandpa when I'm talking about this. Think about your grandma when I'm talking about this, right? Think about someone who you've had it as a patient while you were a tech and you really cared about a lot that might have been a little bit older, okay? So keep them in mind while I'm talking about all these things, and it'll help you retain all the information I'm about to give you. So chronic illnesses in older adults, it's pretty straightforward. Altered mental status is very common. It could happen for a lot of reasons. You can have altered mental status because of a UTI. You could have altered mental status because you have dementia and it's the beginning stages. You could have a TIA and that will cause you to have confusion. You'd have an infection. I mean, it's pretty straightforward. It's only a handful of things, which is the great thing about it. So altered mental status, what do we do? What do we not do? I can tell you what you don't do. You don't put your hands on them. You don't restrain them. You don't have 15 people crowd up in the room at one time, right? In an acute care setting, I always worry about my altered mental status patients, because when they do grand rounds with these internal med docs, I'm the first one in the hallway to be like, nope, these students aren't going in. Because if you were a person who was confused and you were laying in bed and then all of a sudden 15 people in white coats come into the door with their cell phones and they're not even paying attention to you, they're just text messaging each other, could you see how that would be a problem? Could you see where you might fight back? Could you see where you might kick somebody in the face because they deserve it? Because they're teaching you that they could care less about you because they're on their cell phones, right? So I want you to keep this in mind. These guys, they need to be told that they're safe. They need to be told, you're safe, and I'm looking for someone to get a hold of that we can make arrangements for so that you continue to be safe. Safe is the word that they need to hear. They need to hear that you're doing something, and they need for you to know that you care. So, with these guys, they're going to get really snippy at you in the beginning, and that's cool. Look at them and go, dude, I totally get that, right? I totally understand where you're coming from. Like, that totally resonates with me. Get down to their level. Go eye to eye. Stay about 10 feet away from them. Drop your eyebrows, right? 50% of your speech and the perception of your speech is your facial expression. And this is coming from someone who clinically doesn't have a lot of facial expression based off of their disease process. So, I've learned over the years how to do this, and it works so well in communication, especially when someone is confused. So like I said, sit down, relax your shoulders, Open your legs up a little bit. Don't close your arms, right? No need for all that because that indicates that you are nervous. Just be as relaxed as you can and go, look, I'm your nurse today. I'm Molly. And guess what? You're safe. I'm a safe person. You're safe in this environment. And I'm trying to find a family member right now that is also safe. Now, here's what you don't do. You don't say, who do I call? Because guess what? They don't know. They have no idea because they have altered mental status. So don't ask them stupid stuff because then they're going to get defensive and go, well, how the heck am I supposed to know? Or worse. So don't do that. Don't put your hands on them. Don't restrain them. I say that twice because a lot of times that's what nurses will do. It's easy to call security. It's easy to get them to put a forehand over the top of the head because they can't move the rest of their body. It is a proven fact. If you don't believe me, try it, but don't get an assault charge, right? So don't do those things. You will probably have to have a buddy come in to be a sitter. So how I approach that is I say, hi, I'm your nurse Molly. You're safe. I'm safe. And this is my friend over here. And he's going to keep you safe while I step out and go call a family member so that you can continue to be safe, right? Because we want to find somebody that knows them so we can get the skivvy on what's happening, okay? I think that's all I need to say about that. So just keep that in mind. And don't forget to look up any supplemental information that they have regarding that in your textbook. Pain. Pain is bizarre in the elderly because you either have one of two things, and there's very little deviance in the middle, but it occasionally happens. Either you have the extreme where if you barely tap somebody or touch somebody or just brush your hand against them, they scream bloody murder because you have somehow assaulted them, and that's because they're hypersensitive. Or you have the opposite, and that's the gentleman who was in the war, right? He's prior military. He's lived a really, really hard life because that's how things were back then, right? They were a little bit tougher because we didn't have the things that we have now and the resources. And he's the guy that's eating mashed potatoes 7 days a week. And when you look at him and go, why do you eat mashed potatoes 7 days a week? You find out that he has an abscess in his mouth. But he hasn't said anything to you about it because he doesn't want you to know that he's hurting. So whenever you see bizarre indicators like one or the other, you need to assess the patient. I know it sounds silly, but if you have a gentleman who has dentures or teeth in his mouth or anything in his mouth, to be fair, if he's got gums even, you can chew with gums. But if he's doing something that's way too soft, like he's only eating applesauce, he's only eating pudding, he's only eating, like split peas, just silly stuff, ask him why. I know it sounds dumb, but a lot of times it's because it hurts their mouth. A lot of times these guys have thrush, right? They got the white spots on their tongue and it physically burns. Like, have you ever cut your lip before and eaten ketchup when you were a kid? Because it always happens when you're a kid. You do silly stuff when you're a kid. I remember I used to habitually cut my mouth, cut my tongue, bite my lip, whatever, and I would have a little sore in the middle of my mouth, and then I would eat McDonald's, which is what? Covered in salt, and I'd throw ketchup on top of it, and it would burn like the dickens, but I'd keep eating fries. Why do we do silly things like this? Elderly is the same. They just keep eating, they mask their pain, and they move on. So if you have someone who's super sensitive, try to figure out what the problem is. A lot of the times it has to do with hypersensitive emotions. And if they are eating bizarre things that are super soft, it might be a pain problem. They might have thrush. They might have some type of tenderness or an abscess. Either way, you need to assess them. Okay. What you don't need to do is just walk over and act like it didn't happen, or be like, that's a bizarre type of diet, whatever, right? That wouldn't be appropriate at all because something's wrong if someone isn't acting right, and that's just all there is to it. Know the common disease processes for older adults like hypertension, diabetes, depression, failure to thrive. Okay, so think about it for a second. I am an 80-year-old person. I am not working. I get a small pension and then I get SSI, but it doesn't pay for everything. So I lose control over who I am as a person. 20 years ago, 30 years ago, I was an interventional cardiologist. right? Interventional cardiologist with a gambling problem. Let's just make a scenario that's just out there. But the fact of the matter is there are very successful people who in their 70s and 80s either had to take care of a kid, or there was an extenuating circumstance, or, they just made a bad choice financially, and they've gone from being the guy to being no guy. So they get depressed, right? They have hypertension because that's just what happens to your heart, to your veins, to your arterioles. They wear down over time, which increases the pressure that you have, which increases your hypertensive crisis, right? And you have a failure to thrive because guess what? If you eat poorly because of your diabetes, it gets worse. If you have poor blood pressure and you're depressed, you don't want to eat, right? So you kind of have all of these things as a milieu that causes massive problems. So make sure that you're educating these guys on healthy habits. I know it sounds silly because how can you be 80 years old and not realize that oatmeal pies are a bad idea? But it happens every day. And I know that because that's basically my family. So I need for you to understand, tell them you've got to get up. You've got to interact with human beings. You are part of the human race. It is our inherent and genetic need to want to be needed by other people. I don't care who you are. It's silly. It's crazy. It's accurate. Okay? So make sure that these guys are getting up and getting moving. Give them healthy habits for diet. Let them know protein's a good idea, right? Sugar bad, protein good. Let them know vegetables good, oatmeal pie bad. Tell them to get up and move around 3 to 5 days a week if you can, right? Because they need to do these things. Now, I love these guys, but here's what they're going to do to you. Well, I had COVID 3 months ago. So what? You're fine now. Your oxygen's good. Your blood pressure's fair, right? I need for you to get up. What's the bigger problem? Well, my back's been aching for the last 2 weeks. Okay, and it's going to continue to ache if you're laying in bed, and then you're going to get a DVT, and then it's going to go all the way into your lungs, and it's going to stop in your heart, and oh boy, are we going to have us a problem, right? So could you not do that? I'd prefer you to not throw a blood clot, turn gray, and gasp for air in front of me while you shake me until you pass out, right? Because that's kind of how it happens. It's not very fun. So make sure these guys understand the healthy habits, like go exercise, get out of bed, have friends. I know it sounds silly, but nursing's really this easy. I swear. It's just common sense. You just don't have the right pictures in your head. And you guys have been really, really nervous, and I get it. So let's rethink the way that we do this, okay? So we also need to know acute care versus ECF placement. How is that assessment going to change? How is that discharge going to change? So our education is going to be based off of acute care versus ECF. Here's an example. When we're talking about someone discharging post-op, or when we're talking about somebody who's discharging post-stroke, we need for them to know all of the things, the signs and symptoms that needs to bring them back in, right? They need to know what to watch out for. They need to know that if you've had a stroke, there's going to be a recovery process, right? And we need for them to know that there's going to be a decline in their normal understanding of the reality around them, because a lot of times when you have a stroke, you're going to have altered mental status. And sometimes it gets worse before it gets better. So they need to know these things. They really do. They also need to know, how high is my temperature if I, have a stageable ulcer on my foot? Like, what's the hot number that I need to come in for and go to the emergency department versus waiting? And the answer is, if you have a temperature, well, everyone's got a temperature. If you have a fever, there, that helps out. If you have a fever of like 101 or above, buddy, you need to go. That's a problem. You need to teach them about infection, because guess what? These guys really don't know. They don't. And a lot of times they're really having a lot of trouble for a lot of different reasons. So we need to really charge hard on these things. Let's see. Encourage patient resident to get moving. And we already talked about that. Acute changes triggering rapid assessment, documentation, and notification. Yes. So here's some things that we need to worry about if a patient is like in a long-term care setting. I'll use long-term care in this example, but I have a patient who's perfectly normal, and then I go to check on them, and as I'm checking on them, they are like agitated. That's bizarre, right? Or they start yelling, or they say they see something on the wall that isn't there, or they just get weird and altered, or they become magically incontinent, right? Like these are things that happen sometimes, and these are big issues because if you can't pee, then your bladder's going to bust. And it does happen. And that's a big problem. So anytime you have an acute change, like someone spikes the temperature, a fever, I'm so sorry, I'm from the South, we just say temperature, it's terrible. So if these things happen, we have a spike in temperature, we have incontinent changes, like we magically become incontinent out of nowhere, or we can't pee at all. Those are big problems. If, we always think about the respiratory depression, that's obviously an issue. We always think about the heart rate going into the 150s, but we don't think about the silly stuff that is the beginning of a big problem. And we don't want that to happen to our patients, obviously. So I talked about stroke, TA, post-education, symptoms recovery, progression of the disease process. These guys need to go, and they need to understand that they need to take their medication. They need to take their aspirin or their Eliquis or whatever they're on. Otherwise, we're going to have a secondary issue. And usually the first stroke is a warning sign, and the second one is the uh-oh, okay? And they need to know that. And sometimes I have to look at them and physically say, hey, listen, I know that this is aggravating, and I know that you don't want to take your meds, but I need for you to understand that I had a patient 2 weeks ago that thought the same thing, and then they had a second stroke, and guess what? They're a vegetable now. And I just shut up, and I just look at them. And I could see the look of uh-oh over their face, and then I let it sit for another 5 seconds, and then I get into it again, right? Sometimes you got to be a little nasty with them, because sometimes you just got to do that for them to understand what's going on. Medication. So polypharmacy is a big problem. And one of the main problems that we have with polypharmacy, and it isn't necessarily the 9,000 medications are taken, it's the 9,000 pharmacies that they get the 9,000 medications from. So part of it is they need to know, especially when they're going to long-term care or they're discharging or whatever, we'll ask them, what pharmacy do you use? And you can tell these guys, because they'll be like, CVS, no, Walgreens, no, I got a prescription due over here at this time. But what you need to do is go stop. Life is confusing enough without you having 15 different pharmacies to go to. Can we just pick one and stick with one? Because as a doctor, I'm telling you right now, as a provider, I need to know that all these medications are the only medications, because if he's getting this over here and that over there, those two could cause a concomitant problem that can give them further depression, suicidal ideation, altered mental status, respiratory depression, like you name it. So we have to know these things, and we have to make sure that we keep it to as little, as few hands as possible those medications are passing through, the better, is what I'm trying to get at, okay? Next slide. Okay, autoimmune disorders and inflammatory mediators. This is a pretty scary topic for most people. I'm here to tell you right now, it is not to be feared at all. Autoimmune disorders, everyone loves to talk about diabetes, SLE or lupus is what they call it, right? Celiac, anemia, Raynaud's. Those are the hot ones that you will always see on the NCLEX. I swear, I could take an NCLEX right now, and I guarantee you these are going to be the hot topics. I even can read half of the sentence and know where this is going to go as far as the question is concerned and what the answer is going to be, okay? So this is how this works. Diabetes. Know the highs and the lows. Know if my blood sugar is 600, that's terrible. Know if my blood sugar is 6, I'm going to need immediate intervention, right? Cool and clammy, need some candy. AKA, if my sugar is low, I need sugar. I'm going to be cold, I'm going to be clammy. If it's 600 or higher, I'm going to be irritable, or I'm going to be comatose, right? Because maybe 600 isn't a great number for me. Know what medications cause blood sugars to go stupid high. Corticosteroids. I believe we talked about that earlier. Lupus. What are we looking at? we are looking at the common signs of lupus, which is a hot topic. So first off, which ethnicity gets it the most, right? What are we checking for? Well, we're checking for redness of the skin that looks like a butterfly rash, right? That's an obvious. We're checking for the warmth. The patient's going to be like, I just don't feel well. I feel terrible, right? They're going to feel achy. They're going to be fatigued. They're going to have bizarre shifts of fluid, right? They're going to have pain. So we need to ask them where their pain is, because sometimes they really can't pinpoint it because it's just kind of everywhere. So the best way to start is to say, where are you having the most pain and what's the location of that pain? And that will get us to where we need to go to understand that it's just kind of everywhere, right? Celiac, we need to know what the problem is, what we're having an issue, what is causing the disturbance of our bowels, and what kind of diet we need to be on to get out of that, right? Anemia, there's a lot going on with anemia. We're not doing that right now. I want you to walk over anemia. And when I say walk over, I mean like brush over it very quickly, understand the bad numbers, understand what's appropriate, okay? So if you got someone with a hemoglobin of 5, that's a big deal. They're going to have a blood transfusion more than likely. And by more than likely, I mean absolutely. And Raynaud's. Raynaud's is one of those things that you'll see as kind of like what I call like a bonus question, where they get into the one time you're going to have this random, bizarre case of Raynaud's, and there's a paragraph on it. Just read it. Just read the paragraph. Know the signs and symptoms. Raynaud's is kind of like the opposite of frostbite in my brain. The skin is very pronounced and it's very obvious what you're dealing with. It's a beefy kind of color. And just like I said, read the paragraph. And that's different from frostbite, because frostbite is like white skin. And I mean like white as in I'm looking at an MRI at somebody's stroke and that brain is dead, so it's just white. I mean, it's white, and then when you touch it, they literally can't feel it. There's like complete insensitivity towards it. So there's no sensation, basically. So know those things. Read that one little paragraph in your book about Raynaud's. Trickle over anemia. I'm not getting in depth about microcytic, macrocytic. We're going to get into that later. I am not going to frustrate you with it right this second. What I want to do is introduce you to a very difficult topic, right? Because anemia can kind of go everywhere. Is it iron deficiency anemia? Is it pernicious anemia? Like, we can go on for days about anemias, and we will, but not right now. Not for the purposes of this exam. So walk over it, like I said. Walk over your lupus. Try to spend a little bit of time on your diabetes. I believe it's a page and a half of stuff. And then move on, okay? Because I need for you to just take a breath. And you're going to go through all this anyways in your lectures when you do those. Surgical debridement. What's normal, what's not, okay? This is really easy. If I have a surgical debridement, is it going to hurt? Yeah, it's going to hurt. It's going to hurt as soon as that nerve block wears off. And a lot of times you don't get one, right? Because a lot of times we're debriding kind of deep. What's not normal? It's not normal if it's got pus and it's stinky pus. I know that sounds terrible and gross, and I'm pretty sure you're eating a snack or drinking something right now. Sorry about it. It is what it is. So pus bad. Sign of infection. High heart rate. Sign of infection. I don't mean like high like 105. I mean like high like 120, 130. Temperature. That's the big one. If you are 101 or higher, you need to get your tail into the emergency department immediately, and you need to educate your patient before he walks out of the door after a post-surgical debridement. Period. Point paragraph. That is your responsibility to educate them. Not your responsibility to debride it. Your responsibility to educate them on what's normal and what's not. And by God, 102 degrees is not normal at all. Pain? Yeah, I'm totally getting that. Not the temp, not the high heart rate, not the other things, okay? Broken bones and wounds. What delays the healing of a broken bone or a wound? Well, there's only a handful of things, so this should be pretty easy. Diabetes, sugar, skin, bad. They don't like each other. They work together non-concomitantly. They are not friends. They are enemies. because when sugar gets too high, your skin says, I'm giving up. I'm quitting. I'm putting in my 2 weeks notice. Okay. What else causes this? Oh, I don't know. Someone who's got diabetes that smokes 2 packs of cigarettes a day, right? Because when we have a broken bone and we have a broken anything really, or if we have a poor wound, those wounds are not going to heal if you smoke. You will lose vascularization in your body, and you won't get enough blood to the area to be able to oxygenate it, so it dies. It's that simple. It dies if it doesn't get oxygen. Really, guys, it's that easy. So I need for you to know that it's going to delay healing if you smoke cigarettes. Well, okay, cool. What if I vape? No, it's still a dose of nicotine. You're still dosing nicotine in your system. And these surgeons, I've literally seen them like poke fingers in patients' faces because they get so angry because they're like, how dare you give that patient a nicotine patch because that patient is post-surgical break with poor wound healing because they got diabetes, and you're going to throw a nicotine patch 21 milligrams on them? How dare you? They will go stupid on you over that. So make sure that you're trying to figure out smoking cessation any other way other than giving them a nicotine supplement, because it doesn't matter. Nicotine is nicotine, right? So maybe a 21 milligram isn't good. Maybe you can get away with 7, right? Just try to find alternatives to increase the presence and potential for wound healing. Simple as that, okay? Oh, here's a good one. Strains, sprains, and breaks. Hot versus cold therapy. What do you use? Well, I'll tell you what you don't use. You don't put heat on inflammation. Heat and inflammation, they love to do the dance, and it's called the dance of getting bigger and throbbing more. So let's not do that. Let's use cold therapy, because cold is going to constrict everything, and heat is going to dilate everything. So if we want that thump, 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 thump that we have when we have a broken foot or broken arm, here's what we can do. We can put our foot down after we've walked for 15 minutes on it, which is stupid, and then we can just throw a bunch of heat on it, because that's just going to fix everything. No, it's not. It's terrible. What you need to do, elevate your extremity above the level of the heart. Stay the heck off of it. I don't care if it's a sprain or a strain or a break. Stay the heck off of it. Put cold on it. But make sure that there's a barrier in between the two of you so that you don't get white skin, frostbite, and then you lose sensation. It's that simple. Got it? You guys got this. Why do we need to elevate these things? Well, I just said it. We need to chill out that blood flow. That's the thump, thump, thump that you get. That's that pulsating pain that gets worse and worse and worse. It's because we are squeezing this area. We are encouraging all of that fluid to dump down into our extremities because we're not elevating it. We are putting heat on it like a silly person, so it's dilating everything, and we are causing it to throb like the dickens. And a lot of people don't know this, so you have to educate them, okay? Gout is in here for the inflammatory mediators, because gout is a really, really nasty inflammatory process. It is awful. It is almost as painful as trigeminal neuralgia. So gout is a big deal. It is often in tests, NCLEX, HESI. I've seen them everywhere. And you need to know 2 things about gout. Maybe 3. So, number 1, it hurts like the dickens. Number 2, allopurinol is your medication to fix it, because it is one of the best anti-inflammatories for gout, period, point paragraph. 1 dose goes from them being debilitated and unable to walk to being able to move around, and then after 2 doses, they are literally running as if nothing had ever happened. And you need to know the one side effect that you have to watch out for, which is Stevens-Johnson syndrome. And Stevens-Johnson syndrome is peeling. And when I say peeling of the skin, I mean it is in layers. I want you to think when we used to play with glue in kindergarten. Guys, you better admit to this, because if I'm the only one, then we have big problems. But remember when you used to play with glue and you'd get glue on your fingers and you would have that peel off stuff that you would be like the residual of the glue when it dried? It literally is like that on the face. right, around the mucous membrane. So you cannot mistake it for anything else because it literally looks like I got Elmer's glue, I wiped it all over your face, I put it in front of a dryer, and then I peeled it back a little bit just to be funny. And that's what it looks like. So Stevens-Johnson syndrome, allopurinol, watch out for it, and directly tied with gout. By the way, gout, what kind of diet causes gout? High purine. So just keep that in mind. And I think that's all you really need to know. Yeah, that should be good. And then don't forget your celiac process either. And I think that's it. Yeah, I think that's good. So just make sure if they do have these signs and symptoms that you are not giving them that allopurinol, because there are alternative medications you can give. They're not as good, but it's better than having Stevens-Johnson syndrome, which is a big deal. There's a small paragraph on that. Graze over it. Please do that. And then that should be good for this slide. Okay. So, integumentary. This is a big one. There's a lot going on because we're going to talk about wounds and stages. We're going to talk about nutrition and how that's key. We're going to talk about all kinds of nasty stuff like scabies. We're going to talk about shingles and psoriasis. We talked about thrush earlier. We're going to kick back onto that here in a second. We got acne vulgaris we can talk about. Like, skin is cellulitis. I mean, there's like 5,000 things we could talk about related to skin. I'm going to make it simple. So, wounds. What's the most important thing when you're dealing with a wound? Nutrition. Nutrition. If you're doing real estate, location. If you're doing wounds, nutrition. It is absolutely key, right? You have to have a nice protein diet. You have to stay away from the sugars, right? Because diabetes and wounds are not best friends. Matter of fact, wounds are usually a result of it. You need to make sure that you're offloading pressure when you have wounds. I know this sounds silly, but this happens, right? So whatever you do, don't have someone with a stage 2 and a stage 3 or stage anything sitting on their behind without turning them every 2 hours. If they're in a chair, turn them every 1 hour, right? Because chairs are usually a lot harder than a bed. So make sure you're moving them. When you have a wound, here's what I want you to know with wounds. Very simple. Know how deep it is. What layer of the skin is it innervating? Okay. Does it have a smell? Because remember, smells indicate certain things. What color is it? And when I say color, I mean, what color is there sloth? Is there eschar? Right? Is it green and pustulous and stinky like a rotting fish? Right? And what we do to prevent, delay, and dare I say heal these wounds. So we're not going to always heal these wounds, right? If I have an unstageable that's bone deep into my coccyx and I can literally see your sacrum, which does happen often, I'm not going to expect for that to heal anytime soon. This could go on for years if they don't die first. So what I can do is I can delay its ability to get worse via turning them every 2 hours if they're in bed, turning them every 1 hour if they're in the chair, right? And I can prevent it by, using the Santal, making sure that I keep it within the wound bed and not outside where the good tissue is because it eats everything, good or bad. And I need to make sure that I understand I'm educating the patient on these things as well, okay? I also need to know, and by the way, let me back up here to the pressure ulcers. I need for you to know every stage of the wounds, okay? Every one of them. I need for you to know what layers it innervates. I absolutely need for you to know that. You're going to need it for every test you ever take, and especially this one, okay? You have to know those things. Acute change in wound. So changes in the wound versus their mentation. So what are some abnormal labs if I have a wound that gives me a mental status change? What would those labs look like? When you're talking about wounds, the main thing that I want you to look at is your culture and sensitivity, because you need to do one of those, unless you already know what stage it is, and at that point it's irrelevant. You need to know your white count, right? Because white count does what? lets us know that we have an infectious process, right? So whenever you have people that go from a stage 2 to a stage 3 and then they have some mental status change or they have a disruption in their normal homeostasis, then you need to go ahead and jump right onto a white blood cell count, because if it gets infected, we can go ahead and start doing prophylactic antibiotic. Then we can go back and do a culture and sensitivity to make sure that we have the right bug for the right antibiotic and then move on forward, right? So you need to know what that looks like, and you need to know what lab values we're going to do, and also any sensitivity that we're going to check. So I think we just got all of that. Primary versus secondary versus tertiary intention. You need to know these. What you need to know specifically with these is what it looks like, right? Is it serrated edges? Is it nice molded edges? Are we leaving it open on purpose? Why would we leave it open on purpose? What's the purpose of leaving it open on purpose? Know those things. Know what it looks like, okay? You're absolutely going to find these on your HESI exam. Not so much on your NCLEX. On your HESI exam, yes. Treatment for common skin issues. What medications are we going to use? So common skin issues to me are like psoriasis. Lots of people have psoriasis. What do we normally use? We usually a corticosteroid normally, right? Do we need to do a thick layer of it? Heck no, that's a terrible idea. Do we do a thin layer? A nice thin layer. We don't rub too hard. Psoriasis is bloody and painful. If those scales and scabs get so dry and they don't have proper medication on them, they will crack and bleed. So you don't want to apply friction on top of it. I feel like these are common sense things. Just be gentle is all I'm asking you to do. Don't go ripping skin off, please. That'd be cool. So yeah, where did I lose my place? Primary, secondary, tertiary intention, got it. Treatment for common skin issues, medication side effects versus intended results. So when we're dealing with, let's see, skin in the sun, that's a bad day. What do you want to put on it to prevent the burn? To prevent that, those little papules, those little spots that you get on your neck and on your face. I don't know, sunscreen? Guys, this is not difficult. This is common sense. You've got this, you've got this, you've got this. All right. What happens if you're OCD like me and you wash your hands too much and you are on your, 5th or 6th day in a row of nursing? Your hands crack and they bleed, and they usually do it at the top of the hand because that's where the sensitive tissue is. How do you increase your tissue? Well, guess what? You don't. You only have so many layers. So what do? You keep them nice and covered in lotion. You keep it smooth, right? You are going to have dry skin if you're constantly putting Sterilite on your hands. This is prevention that you're always going to need to know. And I believe that it would be important for the purposes of an examination that you understand the simple concept that you have to take care of your skin. And that if you excessively wash your hands, they're going to get dry, cracked, and bleed. I know this sounds funny, but I didn't know how bad my hands can bleed until COVID happened. And I was literally spraying chemicals on me that I was told to put on. And it was told like this: hey, you're going to die of COVID anyways, more than likely. If you spray this on you, you'll probably get cancer. It's going to burn really, really bad, but at least you won't give your kids COVID, okay? So we introduced topics like self-care for nurses post-COVID for that reason, because a lot of us are just used to slathering Sterilite on our hands or, God knows what chemical on us, because that's what we had to do when the apocalypse hit. And that's what I relatively call it, because, the whole world stood still. And a lot of those people standing still, unfortunately, passed away. So make sure you have self-care. Make sure if you're washing your hands 9,000 times a day because you got multiple shifts you have to cover, make sure that you're putting lotion on them and keeping that skin from ripping and cracking and breaking open so you don't get an infection yourself. If you're no good, what's the point of even doing what you're doing, right? All right. So scabies. All right. You want to ever freak out a nurse? Bring bed bugs or scabies. We don't care about anything else except for bed bugs, scabies, and lice. That's the only thing that can freak out a nurse. I swear. I'm a full proponent that those are the big three, right? Like COVID, meh, no big deal. We're over it, right? We were over it 2 weeks after it happened. We knew it was going to be a thing. We knew it was going to go everywhere, and we all accepted it and embraced it. But I swear to God, you give us scabies, or you give us bed bugs, or you give us lice, and we are all tripping. We are in hazmat head to toe, okay? So I need for you to know what scabies looks like. And the reason I say this is a lot of times you're going to get this cute little kid who's like 17 years old. They're going to come into your emergency department. They're going to be like the coolest, sweetest kid ever. And they're going to just be itchy everywhere, specifically in the burrows in between their knuckles, right? You're going to see like these streaks. They're kind of wavy. They're kind of streaky. They're like striated. And they're going to constantly be scratching them. And you're going to think that they have some kind of a tick. And I don't mean like a literal tick. I mean like a tick like they have OCD kind of a tick, where they're just fidgeting because they're anxious, right? It's easy to mistake these, but if you get a good look at those bad boys, you will realize very quick that it's because they are burrowing into the crevasses or the crevices of the skin, and they are laying eggs, and it's disgusting, and it's not their fault. So you need to know what cures it. And I'm going to be honest with you, what cures it is lice shampoo. We actually put lice shampoo on their entire body, except for, the lady or gentleman parts, and then no mucous membranes. And we let it chill for literally about 18 hours. And that's what kills them. And not much else kills them. I don't need for you to know incubation period. We're going to get into that later. I just want you to understand the basic concept that scabies bad. Watch out for it. And what are you looking for specifically that tells you that that's scabies and not something else? Because you need to keep an eye on that. It happens a lot more than you think, okay? And then the whole nursing crew sticks them at the end of the hallway, and they keep one nurse on that guy and only one nurse for the day and night shift. So if you work 3 days in a row and you got that patient, you might as well just get over it. You got them until the day you're done. It is what it is. We talked about psoriasis. We talked about... psoriasis. What is a good alternative to medication besides the corticosteroid that they're going to be rubbing on you very gently, because we're not going to rip off skin, guys. We are also going to give you something for the crazy itching you have, right? Because psoriasis is scaly and itchy. It's like lizard skin. It's miserable. So we're going to give you something like an Atarax or a Benadryl, and that's for itching. But what's the side effect? The side effect is you're going to be exhausted. You're going to have a hard time just keeping your eyes open, because sometimes we have to dose these guys with like 50 milligrams versus the 12.5. Make sure that you understand if you're in an acute care setting and you're giving someone IV Benadryl, it's going to burn like the dickens, so you better push it slow, and you need to dilute it with saline. And I'm talking like 10 mLs if you're doing 12.5, right? Which is what we call a baby dose. The standard dose is like one Benadryl pill is 25 milligrams, just so you get an idea what that looks like. What system of my body is it going to affect? Well, you're going to say my integumentary system. Good job, ding, ding, ding. But it's also going to affect my nervous system, which is why I'm sleepy. So it's also going to potentially mentally alter me. So you need to make sure that you can separate the two. If this is an 80-year-old man with a history of psoriasis, and we give him some Benadryl and he has altered mental status, well, that's probably a problem, because if he has a history of psoriasis, he's used to the Benadryl, right? If I get a 17-year-old kid and he has altered mental status and he's got psoriasis, and this is like his second treatment of Benadryl, and he gets altered mentally, I'm not so concerned, because that's an expectation, because most people aren't used to taking that much Benadryl, okay? So just keep that in mind. Acne vulgaris. What medications can you take? What medications can't you take? What medications should you watch out for? We're going to get into that a little bit more in depth later, right? Because you got the Accutanes, which is going to cause you liver failure, which is never a good idea. You can't be pregnant if you take it. There's certain medications where you can't take birth control pills if you're taking that medication. So what I want you to do is I want you to spend a little bit of time. This is the first time I've actually asked you to spend a little bit of time. One more time. A little bit of time understanding the medications and the contraindications of those medications, specifically the big ones, right? So what medications are going to destroy my liver? Accutane's your answer. What medication can I not take if I'm pregnant? Tetracycline, Accutane, right? What medications can I not take with birth control pills because it's going to increase my risk of stroke? Okay? Those are the ones you need to look at. Beyond that, understand the concepts, move on, right? So let's see. Cellulitis, signs and symptoms, location and treatment. All right, cellulitis, signs and symptoms. Hot, red, shiny, wet. I don't know how else to say that, guys. Location, foot, leg, arm, abscess of the belly. Anywhere that there's a bad area that went bad, that didn't get treated, there's your boy. There's your answer. What I mean by location in this case is specifically, is it superficial? Is it deep? A lot of people think that cellulitis is superficial. Nobody, it's deeper than that. So I want you to understand that it goes into the next layer most of the time. And if it gets to the bone, then we're talking about osteomyelitis. So don't get the two twisted. They're two totally different things. It starts off as one, it ends up as the other. So cellulitis, signs and symptoms, really nasty, shiny red, hot, scalding hot. You could feel it 4 inches from the site of location. It's that hot. Okay. Treatment, and what do you do with that? Cellulitis has a couple of different therapies. Spend a couple of minutes understanding that. Spend a couple of minutes understanding that it's not just surface. It's actually from the inside out and not from the outside in, not the inside out. Does that make sense? Anyways, read it and understand it goes deeper than just the surface layer. Sorry, I had to take a drink. Wounds and healing, post-discharge, emergency signs and symptoms. Again, if I have a wound and I have a temperature that is above 101, above 100.5, I'll give you that one. You need to tell them that. You need to tell them, watch out for pustulous tissue, watch out for stinky tissue, watch out for things that go red and hot, watch out for altered mental status. Understand those. Expect them to understand the fact that healing is going to be delayed, especially if they have diabetes. Let them know that ahead of time. Tell them not to get frustrated. Okay? Infantigo. Infantigo, know your signs and symptoms. Know that they're crusty, nasty lesions. Know that you can't touch them and then go grab your child's face and give him a kiss, because that's stupid. That is flat out diggity dumb. Okay? What you need to do is you need to make sure that everything is washed. You need to make sure that you have one towel for that person, and you need to make sure that you are keeping things nice and clean, that you're washing with soap and water. We're not using an alcohol derivative. The answer is not drying it out with alcohol. A lot of people use alcohol. That is a silly idea. That will encourage it to get worse and encourage it to spread. That's bad. Antibacterial soap and water is your jam. That's how we keep these crusty lesions from getting crustier and spread about. We also need to know prevention so that other people don't get it. So put everything in the wash immediately with hot water. Throw everything in the dryer immediately with hot water. Use gloves when you're handling dirty stuff. And keep other things away from other people, right? So don't go doing your laundry with one kid that you do with the other when you're dealing with something like this, because you don't want to spread it. And for the love of Pete, wash your hands, wash your hands, wash your hands, soap and water. Soap and water is your answer to everything in this whole world. Soap and water is your friend. That's all I got for this slide. All right, so when we're talking about visual problems, I tried to not make this such a big deal because eyes, I've said this a million times if you haven't heard it already, eyes are very important, but in an acute care setting and in a long-term setting, to be quite fair, we're rarely going to care about them, right? Because there's only a handful of things that can go really, really wrong when we're dealing with this. And the big things that we need to talk about, we're going to talk about, and those are usually the same ones you're going to see on your NCLEX and every other test in the whole wide world that has anything to do with nursing, because everyone understands eyes are for ophthalmology, and ophthalmology is an outpatient deal that is done with a scheduled appointment, which is not convenient for long-term nor acute care. So we're going to hit the hot spots and we're going to be done, and that's it. It's going to be an easy one. Life is peachy in this realm, so I don't want you to freak out with eyes, because there's 1,001 pages about eyes, and it's a little intimidating. I'm not going to lie to you. But we need to know the big things. So, like, we need to know eye trauma. We need to know eye emergencies. We need to know glaucoma, and when we're dealing with intraocular pressure, what the normal limits are, what it is to be too low, what it is to be too high, right? So let's go from the top. So know your terms. And the terms are literally at the beginning of the chapter. It says key terms. It's in a big blue bar. Read those. Know the difference between diplopia and ptosis and keratosis, etc., etc. Know what one does, how one presents versus the other, right? So if you have a droopy eye, know that that's associated with, its disease process, right? Or its problem process is a better way of putting it. I don't need for you to know necessarily how to fix it at this moment in life, but walk over it if you don't mind, okay? I don't need for you to know 9,000 eye drops. Not even close. Wouldn't dare. That's not right. What I do need for you to know is that when you're dealing with glaucoma and eye drops, and my Monday crew knows this spiel because I gave it to them, in an acute care setting or in a long-term care setting, if I had $1 for every time a nurse put not given on an eye drop, patient refused, not given, or in a long-term care setting where they get on their MAR and their TAR and they do the same, I would literally be as wealthy as Elon Musk, I swear. So, these people with glaucoma, it is incredibly painful. I want you to picture your eyes in a vice grip, and that's what glaucoma feels like for some of these people, because it is a ridiculous amount of intraocular pressure that is squeezing, physically squeezing. So these eye drops will relieve that pressure, okay, through a ridiculous process that I'm not even going to get into right now. But what you need to know is they have to have these things for life. They have to have them once or twice a day, and there is no joke about it. It has to be done, right? Do not do this to these people. There is a balance in this universe, and if you walk away from these people and they get pain off of that, the universe has you on point, and they will make sure that you get exactly what you put into this world. Please understand that you need to watch out for that, and please understand these are medications they're going to have to take forever. It's not going to be a temporary deal where you take it for 3 or 4 months. It's every day on time. Those eyes get used to getting them at a certain time. So when they call you at 6 o'clock in the morning and your shift is over at 7 and they go, I need my eye drops, by God, they do. Because they know by 7:30 it's going to start aching, and nobody wants achy eyes. It's the worst. It is literally just terrible. So no fun. I think I've made my point. Take care of that. Know your key terms. Also know the difference between the 6 cardinal gaze positions, right? No Snellen, which I managed to put Snellen. I'm actually going to leave it because that's funny. Corneal reflexes. Know what I need to do in order to do that, and know what type of eye problem that you have in order to need it. Does that make sense? So, what do I do if I have vision changes? Which tests do I need to do? Well, I need to get a baseline because I've never had eye problems my entire life, so I need to use a Snellen, right? Because that's going to tell me what my vision acuity looks like. Know that blindness is 200 vision, right? There's a slide on it in your eyes. Go back to it as soon as I post it, read it, listen to it, whatever you need to do. And just understand that simple concept. Understand what you need corneal reflexes for, okay? Know your emergency conditions. Know if I'm seeing massive floaters and flashes of light, that is an emergent condition. And that is a problem. And I have got to seek help immediately because I will have permanent vision loss within hours because that is an absolute retinal detachment. That is a big problem. Know your big problem players. Jumping over to cataracts. Know cataracts. Know what the signs and symptoms of a cataract are. Know the treatment of a cataract. Okay? It's literally a paragraph. Read it, please. That will absolutely be on every test that you ever take. Cataracts, glaucoma, intraocular pressure, and emergencies. That's what you're always going to see for your eyes. Know your rods versus your cones and what does what. Which one does this acuity, which one does that. Okay? Know convergence, accommodation, refraction, etc. Okay? And know how to test for those things as well. Accommodation is very common that you're going to check. Know what test you're going to check when you're dealing with accommodation, and so on and so forth. Make sense? Okay, that's all I got for this slide. This is the easy one. Okay, so with auditory problems, you only have a handful. They're usually big problems, which is why they're in your book. So you'll normally see the basics, right? So you'll see the hearing loss or the presbycusis, which is like the sensorineural hearing loss that's age-related, right? So this is going to be different than what they call ototoxicity. Now, ototoxicity is I've had a toxic amount of medication and I get ringing of the ears or tinnitus, and sometimes I have permanent hearing loss. This is a major problem with one specific medication, and that one specific medication is, this is the part where you should be saying Lasix. Lasix is notorious. So I'm not talking about an 80-year-old gentleman who turns the TV up way too loud because he's trying to cloud out the volume of his ears ringing, because that's an age-related problem that, again, is kind of a presbycusis. I'm talking about the gentleman who is in his 50s, usually has great hearing, and then all of a sudden he's like, wow, that's weird, as soon as you push that Lasix. And they grab their head and they go, oh, that ring, oh, that's so annoying. Or even worse is when they look at you freaked out with eyes bulging and they're trying to talk, but they can't really hear what's going on for them to talk, so it just sounds like a bunch of nothing. Now, is this a permanent problem? Sometimes it can be. All I need for you to know, Lasix, big problem if you push it too fast, ototoxicity. And Lasix is always going to come back because it can cause our creatinine to get too high. It can cause us to get dehydrated. It can cause us this. It can cause us that. It can cause ototoxicity. So Lasix is one of those medications that is a great medication. And I tell you, when I need it and I need it fast and I need those lungs to get cleared out, boy, does it work like a champ. However, there are a lot of underlying factors that can cause a couple of problems that aren't as big but are just as annoying. So again, presbycusis, normal. It is sensorineural issues that have nothing to do with that versus ototoxicity, which is the Lasix, which you push too fast. Okay, so that's basically all I need for you to understand. I also need for you to understand the term tinnitus, or ringing of the ears, presbycusis we just talked about, otorrhea, all of those things that are in your key terms. I want you to walk over what the key term means, what it's associated with. What is it more than likely associated with? So let's see. Again, going back to Lasix, it would say something along the lines of, what is something that the patient needs to worry about, or what is something the nurse needs to worry about when administering, furosemide to the patient? And of course, you look for ototoxicity, something that simple. Presentation of a patient with hearing loss. Oh yeah, this is classic. So what does that look like when a patient has that hearing loss that we're talking about? Well, you're going to get that, right? Because they want you to speak up because they can't hear you. Those are classic. They'll say, speak up. They'll cup their hand, right? You'll ask them how high they turn up their TV, and they are literally going to be leaning into the TV or cranking up the volume. These patients, you always get the classic stereotypical patient is the gentleman who's in his 90s, and I can hear Fox News from the nurse's station because he's that deaf. And those guys, we just shut their door kindly, and we write them a little note that says, hey, I'm going to shut your door. It's awful loud in here. And we need other people to kind of relax a little bit more, and talking heads screaming at each other about something that is never going to change is not going to fix the problem. So make sure you shut your door and give them a little bit more privacy because they can't hear. A lot of times we have modifiers like, they call it turbo ear or an amplifier. A lot of hospitals have this device that just raises the amplitude. It isn't going to fix the problem, but it makes it a little bit easier for them to process the information that is going into that area of vibration so that it can pick up what you're saying at least a little bit. So yeah, classic signs. Speak up, I can't hear you, right? Television volume, you can hear from the nurse's station, it's so high. They kind of tilt their head and they lean forward. This is what I call the personal bubble break. So you'll have a gentleman or a lady who says, I can't hear you. And then all of a sudden they get 6 inches to your face and all you see is their ear because they tilt their head and they literally want you to shout into it. These guys, believe it or not, a lot of times, this isn't really an auditory problem. This isn't really a neurosensory problem. This is you need to get up in their ear and elephant wash it out. I had a patient who was with us for 190 days at this point. He's still there. who is deaf and blind, but it turns out that he had one good ear, and that was on the left side. And the reason I found out is we were literally shouting into his ear for weeks, to the point where I got a sore throat and I lost my voice because it was that loud. And I looked in there one day and said, I wonder if I just kind of pat around what happens. So I got a cloth and I cleaned around the inside of his ear, and oh boy, did clusters come out, right? So we did an elephant wash, and literally this little buddy came out. And if you put your thumb and your forefinger together to make the letter O, that's how big it was. Yes, my friends, that's how big it was. And guess what? We can hear now. It's amazing. It's a miracle. A lot of people who are elderly and they have multiple disease processes, like they're blind or they have, urinary issues, they have kidney problems, they have GI problems. They're not really caring about their ears so much, so they'll let it go. And we just think, they're old, they're losing their hearing, yada, yada, no big deal. But it's not. So make sure that you're just kind of peeking in there, or that you are referring to someone in ENT that can do that for you. Let's see what else I'm missing here. Oh yeah, so we're gonna obviously talk about the big guys. So Meniere's is always a big deal. Any type of otitis media or ear infection is going to be a big deal. And here's why. Like ear infections, they're usually pretty well handled. You usually just kind of get over it on your own. However, when you have something that's bulging, it's going to perforate, and poking a hole in it, right? So it's literally going to blow your eardrum if it gets so bad. And one of the things that we look for when we do an inner ear check is we're looking for that beautiful gray shade that's flattened right at the eardrum. It's smooth, it's shiny, it's beautiful. That's fantastic. When it's bulging and it's blue, your eardrum's about to be through. Just remember that. When it's bulging and blue, your eardrum's about to be through, because it's about to bust open, buddy, because it has had it. It has had it officially. So make sure that you understand the difference between those things, okay? Let's see. Meniere's. So Meniere's is near and dear to me because I have it. So it basically is hearing loss that you have very, very young in age. It usually starts off with you have 1,001 ear infections as a child. You spend most of your day drinking the pink stuff. And if you know what I'm talking about, you know what I'm talking about, the amoxicillin. That's the liquid form. And nothing ever works. You just keep getting these recurrent ear infections. Well, in your 30s and your 50s, that turns into you having paper like rubbing into your ear kind of a sound. And then whenever you have a change in barometric pressure or a weather change, so like the fall or the spring, you literally go deaf. And it's literally for like a month. And in my case, it's in my left ear. There are genetic proponents that are related to this. Some people have it because they've just been around too many M16 rounds in the military, too many shells and too much shrapnel. Those guys, that's part of what they call the shell shock system. Is, you have this altered mental state, you get really upset, you have a lot of anxiety, and your ears, they knock you off of your equilibrium. So that's part of the shell shock proponent. So you literally go from walking straight to out of nowhere, you are off balance, nauseous, and ready to fall over. So you want to make sure that you always have some Dramamine near you, because that will help you out. Specific to Meniere's, there's a lot of going on. It's probably 2 paragraphs long. I encourage you to read it, because these people will look like classic hearing loss patients. Only the difference is going to be they're going to come in around their 30s and they're going to come in with dizziness. Dizziness not otherwise specified. They're not going to be orthostatic hypotensive. They're not going to go, what the heck's happening to them? They have no idea. And if you try to walk them or you try to lift up their bed rail, they're going to snatch onto the side rails as fast as they can, because it literally is that bad. I say literally a lot. Wow, I really do. Somebody count that one day and see how bad it is. I need to get rid of that because it's annoying. It's annoying to me, and I'm the one saying it. So let me back up and digress and not say the L word again. So with Meniere's, I need for you to understand just a couple of simple concepts. This is something that presents itself between the Middle Ages. It starts off early, but it's usually masked by the fact that a person has recurrent otitis media issues. We normally have an issue with diet. This is usually a salt problem. So you need to make sure that in order to prevent further attack, that you have a salt restriction if you can. Fluid restrictions also help. Sometimes if you're dealing with something more related to having that bulging eardrum that's helping cause the problem, but I would make sure that I really watch that, because you don't want someone to get dehydrated. But the bigger thing is stay away from salt. Just remember, food's low sodium, good. Let's see what else would be something that we need to talk about that I haven't gone over yet. I think that's about it. BPPV, know the difference between BPPV and Meniere's. I feel like I've already said it. BPPV is a totally different situation. It has to do with crystals in your ear. It's kind of a wild ride how they do the therapy for it, because they literally slam your head down and then slam it back up so that we can move those crystals around. So make sure that you understand what that is, because that's a big deal too, especially with neurology, because they're going to ask you when you have these patients, is the room spinning or are they spinning? Because that's absolutely going to dictate which one of these you have. So let's see, let me run back. We talked about ototoxicity, presentation of patient with hearing loss. We talked about that. Ear exams, normal versus abnormal. We talked about that. Meniere's, diet, treatment, got that. How do we communicate with patients? Oh, this is a good one. So patients, we don't want to shout. That is a silly idea. This is not a problem of amplitude. This is a problem, in this case, when we're talking about neurosensory hearing loss, this is a problem with decibel level. So the higher decibel level you have, the harder it is for an older person to hear. So if you ever want to play a practical joke on someone, not that I ever have, you can literally hack into someone's PowerPoint presentation, not mine because I'm still young. You can hack into their PowerPoint presentation and say whatever you want to, so long as it is at a high decibel level, and they will never ever hear it, but all of the students will. And it's super, super funny. At least I would imagine it would be, because I would never do things like that. So know your terms. Know how we communicate with patients. We don't yell. We don't talk fast. We enunciate. We give them modifiers like turbo ears. We give them whiteboards, whatever we can to communicate with them, because it's really scary stuff for them. And then tinnitus, what causes it? What do we do when we have it? We kind of got into the ototoxicity issue. Tinnitus is simple. It's ringing of the ears. This is pretty common. You will have people, like I said, who will crank up that TV and it's blaring all the way over, and you say, what's wrong with you? And they're like, I'm just trying to block out the ringing in my ears. And you go, oh, okay, well, there's other things that we can do for that. So make sure that you understand, because a lot of times there is intervention we can give them. They just don't know. They think that this is the only fix because their grandpa was that way, their mom was that way, their dad was that way, their older brother was that way, whatever that looks like. So like I said, walk over your key terms, get to the major illnesses that are an emergent issue, right? Know your basic issues that are going to throw off your equilibrium, like Meniere's and BPPV, and you guys should be set on this one. Okay, friends, finally we have math. Now, I'm going to be honest with you, there's 5 questions on math, as you can clearly see in the first slide. These are not hard math questions. I want you guys to start off really great. I want you guys to feel confident, and I want you guys to understand that you're going to trust the system, and we're going to trust what we learn together, all right? And we're going to trust each other as a team. So I'm going to give you the easy peasy lemon squeezy math this time, okay? So the silly things. I'm not going to give you some ridiculous calculation that's going to take you 15 minutes to do. I am, however, going to challenge you, because when we did our math review on our simulation days on Friday, there were a lot of people that messed up on this one math question, so I decided to choose it, and I'm going to absolutely let you know what you're going to have to do. The question I'm talking about isn't the difficult GTT question you're probably thinking. It's the one where Sally sells seashells by the seashore, and she came in because she was so dehydrated. So we're going to do strict eyes and O's to hydrate her. So Sally got a liter of fluid and got 4 popsicles and got 15 juices that were 4 ounces apiece and got 2 tablespoons of amoxicillin that was tinctured down to a liquid, yada, 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 right? And then on top of it, they urinated at, 800. So how many mLs have I grossed for the day? So what is my value after all of that's considered, right? So everyone really struggled with that, to be fair. There were a couple that just blew through it, no problem. But in order to do this, you need to know how many tablespoons, how many mLs are in a tablespoon, how many mLs are in a teaspoon, how many mLs are in an ounce, how do you convert a liter to milliliters, right? Like, you need to do that one. And that one is absolutely going to be there. I'm just letting you know. Like, absolutely study the heck out of that question and understand it and know all your silly little calculations you better talk about. I've even seen questions that literally say a quarter of a cup of something or a quart of something. Like, you need to just back up the train, whoop, whoop, and go back and understand that stuff, please, because you're absolutely going to get thrown with this one. So when you get it, don't freak out and don't act like you didn't expect it, because literally it's on your slide and I will know you didn't do your review. So do it. And you can do it. It's not a big deal. I don't want you to be afraid of it. And it is something that we have to do on a daily. So you really need to get in the habit of it. Okay. That's literally all I have for the slide. The rest of the stuff is super easy stuff. Okay, so this is important because this is from years and years and years of college and me doing the wrong things and learning how to do the right things. And remember, guys, like, I've got a couple of degrees. So I've been in school for the last 12 years, and I'm going to be in school probably until the day I take my last breath, because I am that nerd that likes to know the answer to many things. But be a master of none. So I know a little bit about a lot of things because of what I do. That being said, I am a master test taker. If you ever need help on master test taking, all you have to do is come to me. I have open office hours. They are posted, I believe. I believe Katrina has them, or I can just tell you, just text me, or we can do a FaceTime, or we can do a call. Like, you guys have met me, you know, I'm totally cool to do whatever I need to, because I understand the student game, because I myself am a student. So just let me know if you're struggling. What I do is I walk over chapter key terms, because your key terms are going to dictate things. I usually read the first couple of sentences with every disease process, right? So, like, if I get congestive heart failure, I'll read congestive heart failure all the way to the point to where I understand that their signs and symptoms are overload. So I don't read all the stuff in between, because for me, there's no need to. Congestive heart failure is an overload. Got it. Okay, move on. Signs and symptoms of this are blah, da, 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 da. Got it. Medication to fix this problem is blah, da, 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 da. Got it. Education on this patient and weights, blah, da, 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 da. Got it. Okay. So I walk over these things on purpose, because at least I'm looking at him. And if I can look at it, I can usually associate it and understand that trigger word when I'm looking at a test. Slow down while you're reading these questions. These questions are meant because here's the scenario. And let me explain why these questions are the way that they are and why they freak you out so much. It's because that they're backwards. Okay. So it will say, which one of these questions tells you that the patient needs further education? And that is a long, long way of saying, what did he just mess up on? Because that's literally all they care about. What did he get wrong that you need to correct? What did he teach back to you that was wrong that needs to be right? Okay? That's how that question is worded. They're going to throw trigger words like acute care versus long-term care. Well, Molly, why does that matter? Well, it matters because if I'm in an acute care setting, I don't need to worry about educating them on a process that's not going to be an acute process. So if I have a patient that broke a leg, do you think I need to educate them on their depression? No, I don't, because that doesn't matter. What matters is making sure that they understand that they could die if their temperature gets too high, or they could die if it gets infected or lose their leg and get sepsis, right? That's what's important in an acute care setting. Now, in a long-term setting, Do I need to educate on depression and the things that they need to do when they have things like depression and diabetes and hypertension and complex processes? Yes, I do. I need to tell them to get off of their tail because that is going to make things worse. That is going to increase the cortisol levels, which is going to increase the diabetes problems, which is going to in turn kill the kidneys, cause problems there, and then cause you to have worse hypertension. Okay, it's that simple. I don't want my patient in a hypertensive crisis. More importantly, I don't want them depressed. I want them to feel independent. And guess what? Now they live in my house. So how terrible is that? Okay, so I need for you to be able to kind of connect the dots and understand that there are things that you need to educate them on in specific settings. So you have to slow down and answer the question. The reason that your instructors always tell you don't second guess yourself is because the way you need to take these tests is not the way that you've taken any other test before. Here's the kicker. You read the question slow. I know it's timed. I get it. But Molly, it's timed. The tests are timed. Okay, cool. How much time does it take when you're reading a question too fast? You answer it, you go to the next question, realize that you screwed up, backtrack to the other one, freak out because you just changed your answer, and they always told you not to change your answer. They said not to change your answer. And then you're so stuck on that you can't even focus on what you were doing in the first place. Tell me how that messes up time. So I need for you to read it like slow poke. Like slow poke. Read it slow. Look for the trigger words. They're going to throw 9,000 disease processes at you sometimes, and they're not even asking about a disease process. So make sure that you understand in an acute care setting, in a long-term care setting, in a home setting, right? Which one of these education points do they need re-education on? Or which one of these statements made by the patient indicates further education? That is literally how it's going to sound. And that is backwards from, man, that boy didn't listen. Which one was it? But that's all they're asking. So don't freak out when you see it. Okay? Other things. Make sure that your patient understands that they need good habits like good diet, good exercise, good mental health. Make sure that self-care is part of your education. Okay? Make sure that your patient doesn't give you silly excuses, and make sure that if they do, you need to understand that those are things that you need to go back and discredit your patient and say, no, that's not jive. We can't let that happen. Okay? Sometimes you gotta get a little difficult with these people. I need for you to learn the why when we're dealing with these things. I don't want you to memorize things. I do want you to memorize things like interocular pressure and know that anything in excess of 24 is a problem, and know your lower limits and what that means as well. I want you to know specifically what the limit is, what the value is, and what the problem is that's going to happen if it's either this or it's this. And by this and this, I mean too low or too high. That would be an example of something I need for you to know the numbers on. Other things like white cell count, other things like your CBC results, your BMP, all of that we'll get into later. Don't freak out about it right this second. Just understand we're walking into concepts. I'm trying to retrain your brain, so this is going to be super duper basic. I need for you to get some confidence boost. I need for you to get a little bit more comfortable with how things go. So I might be putting the training wheels on this test a little bit, and that's good because that's exactly what you need, especially with this missing a week. Like, it is what it is. If you were in a panic while you were studying, you pause this as fast as you can and you walk the heck out of the room. If you were in a panic, you better call me. If you were in a panic and you don't call me and I find out, I'm coming for you. I'm going to be angry. And by angry, I mean disappointed, because I am going to answer that phone every single time. Anybody that's texted me knows I answer within 5 minutes. Every time. Because that's how much you guys mean to me. You guys are my children. You guys are my cousins. You guys are my uncles. You guys are my family. I am not going to refuse to talk to you, okay? No matter how many times you bother me. If you were in a panic and you were getting chest pain and you were getting tightness and you were getting the burning stomach and your head is hurting and you want to cry uncontrollably, but you know if you say another word you're going to lose it, call me, text me, Send a message out. Send an SOS. I will talk you off a wall. I promise. I'm really good at it because I've done it a million times. Only I didn't have anybody. And I swore if I ever got in this position, I would be there for everyone. And by God, I am. So there you go. Reach out to me. My number is literally in red. Look at it. It's right there. And then look at the other one that's in red. If you get confused, send me a text immediately. I'm not saying this to feel good about myself. I'm saying it because you need a resource, and sometimes you need a mentor, and sometimes you just need a friend. And although I can't be your friend, I can be your mentor, which is kind of the same thing. So reach out to me. I don't care if you cuss. I don't care if you're frustrated. I don't care if you scream, right? I need for you to get it out of your system so we can get you back to chill so you can go back to studying, okay? Don't forget self-care. I need for you to study a section because some of these lectures are going to be long. They're going to be in excess of an hour, right? Because I'm talking about all these concepts and I'm trying to get you to learn it because I know that you can't read 1,000 pages of material while you're trying to take care of a family and work 2 jobs. Hi, how's it going? Name is Molly. Nice to meet you. I've been doing it. I get it. Okay? So I'm going to send you some really long videos. Some of these videos, I'm literally going to read the chapter to you because I thought about it and I thought, I wouldn't be able to read that much if I, weren't the person that I was and hadn't been doing this for 1.5 billion years. I remember what it was like in the very beginning, thinking, why God did they make me read 300 pages in a week? So I am literally going to be your audiobook. So get used to this accent. So sorry. At least you have the resource there. So if you need to not read because your eyes are hurting, cool. Put in what I call the audiobook where I physically read the chapter to you. So at least you can hear it. I think it's fair. If you have a problem with it, let me know. I'll stop doing it. I just think it's a good idea. It just kind of came to me. Do your self-care. I need for you to walk away. I need for you to get out and do some things. I need for you to put in a podcast or one of these lectures while you're at the gym and I need you running. I need you blowing off steam. I don't care how you do it, as long as an assault charge isn't warranted, right? I need for you to run. I need for you to go play kickball. I need for you to go to the salon. I need for you to go pump some iron. I need for you to do whatever you need to do. What I don't need for you to do is to drink or to smoke or to vape. Don't drink a bunch of energy drinks. Those are terrible ideas because what it does is it trips your brain system and it deoxygenates you. And when you're deoxygenated, you freak out because you have altered mental status, even if a little bit, right? So don't do those things. I know you're going to do them anyways, but don't do them. Don't drink alcohol and study. Don't study, get stressed out, and then drink alcohol. Guess what, friends? You're going to forget everything. I don't know how I know these things. I just may or may not have met people that have done it, and it did not go well for them, and they failed. Don't be that person. Don't drink 15 energy drinks. Don't drink a whole pot of coffee while you're trying to study. Don't study until 4 a.m. I know that these sound like stupid things, but I tell you, if I'm yelling about it, that I've either dealt with it myself or I have had somebody else that has drank, smoked, vaped, or drank way too many energy drinks or alcohol, because I would never do those things. I call it energy drink, smoking, vaping, and alcohol bad, otherwise known as operating textbook while intoxicated. Don't do it, guys. Don't do it. Don't do it. Don't do it, because you're going to hate your life if you do it. Don't do it. Okay. I'm done with this. Next slide. Okay. Final thoughts. You know how the test is going to go. You know what to expect on the test. I'm going to give you supplemental lectures. I'm going to do it soon, probably in the next 24 hours. You're going to get some slides. Some of them are going to be 115 slides. Some of them are going to be over an hour long. We have until Monday for my Monday crew. We have until Friday for my Friday crew. And Monday crew got a big fat lecture, and it went really well, I thought. And most of the things that we talked about in that lecture, if you notice, remember how I said, I don't know what the test is going to say, but I have a feeling we're going to go over these things. And are you seeing it again? The answer should be a resounding uh-huh. So, take the time. Listen to the lectures. I know you're so tired of hearing my voice. I am too. I'm so tired of hearing it. But do it. Trust it. Okay? I am not here to throw you off. I am not here to hurt you. Did I mention everything that's going to be on the exam? Because I know that question is going to come up. Because they're going to be like, hey, how can I learn the least amount of information the fastest I can? And look, I dig it. I get it. Other people don't get it. I do. I've worked the 2 jobs at the same time. Heck, I do it now. I've gone to 3 colleges at the same time. Heck, I'm doing that now. I've done the multiple degrees at the same time. Heck, I've done that now. I just finished doing it, right? Like, I've done it. And the quicker you can get the info in your brain, the better. However, in the case of nursing, you cannot do that. People will die on your watch because you memorized early. That's a terrible idea. You cannot do this in nursing. People will die. You can do this if you're getting a liberal art degree. That's cool. You can do this if you're getting a statistics degree or a physicist degree, right? Like, if you want to do astrophysics, great, fine, whatever. Cram and do it fast. Not with nursing. People will suffer. People will die. You will watch it. And the worst part is for a while, you'll think it's everyone else's fault but yours until you realize it's your own ignorance that caused it. And then you got to live with that for the rest of your life. Don't be that person. Don't. Please don't be that person. You're better than that. You are put on this earth to save the planet. And I'm not being funny, haha. And I know that you don't have an S on your chest, and I don't even care. What I care about is you were born with a spark in you and a light within you that was different from everybody else's. You had the power to create or to destroy, just like everyone else. But yours is special because you have the ability to influence others. These people are homeless. These people are abused. These people have been tortured mentally, physically, spiritually. These people are afraid. These people need you. They are at DEFCON 1. They are at maximum capacity and critical mass. And you are the chosen to be able to calm them down, to put them back in a parasympathetic state, and for them to manage their existence, whatever that looks like for them. You need to love them as they are right in that moment. It doesn't matter what you believe in. It doesn't matter how you feel. It doesn't matter what you think, because guess what? You don't matter. And you know what? When you say that out loud, it's very liberating. To spend X amount of years to learn your craft so that you can look at somebody and go, you know what? I don't even matter. You do. To be and to feel that selfless is one of the greatest rewards ever. And I know you think I'm nuts, but trust me, when you do it, you'll get it if you haven't already done it yet. And to my LPNs who do get it, I'm proud of you. Good for you. So, you guys can do this. I need for you to slow down and quit going so fast. The world is still going to tilt on its axis. It is still going to rotate. If you take an extra 10 seconds to read this question and understand what they're asking you, you will succeed. If you blow through this test and you don't pay attention to the question, you're going to be in my office, very upset, not because you missed the question, but because it was an easy question and you missed it. Does that make sense? So, my final thoughts. I am here for you if you need me. I know what it is to be alone, and it's an absolute misery. I know that burn in my stomach, and I know you know what I'm talking about. I know that pain in my head, and that migraine that you get, and that pain in your neck that you get that goes all the way down into your shoulder blades and burns, physically burns. I have done it. I have been there. I have done it recently. I get it. I am here for you. I am here for no one else but you guys. So use the resource. If I don't know the answer, I know someone that does. I'm the person that's got a guy for everything. So just let me know. Second off, I am proud of you. I am absolutely and unequivocally so incredibly grateful and proud of you, because it is not an easy task to do what you do. Don't think that I don't know. Don't think that I don't know what it's like to take care of kids, to go to jobs, to be able to afford your education, and to risk it all for a spark, a chance, nay, a small value of a better chance at a better life. You are literally sacrificing who you are right now for who you're going to become. And I could not be more proud, because most people don't have the guts to do what you do. And I need for you to get that. No matter what happens, you need to get that. And by the way, what's going to happen is you're going to succeed. So good for you on that, if you take the time. So next, you've got this. These are easy concepts. Nursing is easy. I've told you this. You think I'm nuts? It's cool. Whatever. Think I'm nuts. I don't care. But it's easy. It's easy because it's common sense. Because we got Uncle Sally, Aunt Joe. I said that backwards. You got your mom and your dad. You've got cousins. You know people that have these disease processes. Think of them when we go over it. I know you have people in your family that have COPD. And if you don't, you got friends. I know that you know Joe, who works at Kroger, has, prostate cancer and what that means. Because you talk to him about it. Because you're a good person. Because all nurses, many nurses, most nurses are inherently great people who have very, very tortured yet gentle souls. Okay? Keep these things in mind. Keep them in your head, because it makes it so much easier for you to understand these concepts when you're thinking about somebody you care about, because then it becomes personal. I need for it to get personal, okay? Trust yourself. Don't second guess. Remember how we waste time when we second guess. Look at the answer, know it's there, mark it, move on. Clear your brain for the next question. You have to. Tap that door frame. My Friday class knows this. I didn't talk about this with my Monday class. Sorry, guys. Friday class, tap that door frame. All that junk when you walk in that exam, I want it at the door frame. I don't want it in my house. No, sir, no, ma'am. Not going to happen. I need for you to literally get all of that aggression out in one fell tap. And I say tap, and if whoever smacked it and almost broke their hand last Friday, good on you, because I really felt that. But don't do it again, because I don't need for those bones to be broken. That would be bad. And if they do break, don't use heat. Heat is bad for inflammation. Okay, I'm done. I'm not going to say it again. So, that being said, tap the door. All of your anger and angst, it sticks on the door frame, and you don't walk back to it. You're done. Okay? Be done with it. No sympathetic nervous systems are allowed in my testing area. Period. Period, point, paragraph. If I have aromatherapy in there, don't freak out. It's going to be there. It's going to be okay. I need for you to be chill. If I've got light music on and everyone's cool with it, that's going to happen too. It's going to be 9. It's going to be white noise in the background, and it's going to relax your brain. I need for you to be relaxed. Am I going to have candies? Oh, you betcha. For sure. I'll make sure they're sugar-free, because we don't want to jack up diabetes, because we don't want to jack up any wound healing from our broken hand that we did not put heat on. Okay, I'm done. I swear. All right, so you guys are tired of hearing me talk. I'm tired of talking. It's midnight. I think I'm going to take a break and then go back to some lectures. I'm proud of you. I care about all of you. You guys are going to do great. Remember your concepts. Remember what we talked about. If you have any questions, or if I started to say I was going to get into something and I didn't, send me a text. Catch it. Let me know so that I can hit it quick. And then my Friday class, we're going to go over it. And then I think I'm going to do an open office hour and or open review, because you still have this. This is fine. I think I'm going to do, my Monday class said Friday was a good idea. I might do my open office hours and do like a quick Zoom so that we can talk about anything else that I missed. So be on the lookout for that. I'll give you my office hours. I think for Friday it's probably going to be about from 6 to 7:30, but don't quote me on it, okay? And I'd like somebody to give me a quick poke via text if I forget to do that, but I don't think I will. So, all right, guys, that's all I got. Be sweet, stay safe. Don't drink and smoke and study at the same time. That's super not a good idea, okay? Don't do all the things and do all the things you need to do. And I'm proud of you. All right, go get it.